hospital and research it in the capacity of assistant professor. She is very much interested in research in palliative medicine, especially in non-oncology and pediatric population. She keeps a keen interest in making palliative care accessible to these populations and improving the quality of life. So with the positive thought that she will be the apt person to guide us through the topic, ma'am, it is over to you.
Thank you so much for the very kind introduction. And hello everyone, I'm Dr. Rutula. So we will start off with a very vast and understudied territory of palliative care, that is the non-oncology, because it's not available I think in most of the places except for Kerala. We are not taking into account Kerala because Kerala has a good excellent palliative care services. Am I audible? Am I well audible, or is it there? I apologize. There will be a lot of disturbances because I'm not getting range inside the room. So I'm
Yes, ma'am,
outside.
you're audible.
Yeah. Okay, great. Just to kind of mention it, I am not going into the details of every disease that is there, which will be potentially a palliative care reference. I will be just brushing through all the main symptoms that are seen in various diseases, and we'll see how that goes. And you're free to ask questions in between and give pointers if that's what you feel. If you do something different in your practice, please feel free to share it with all of us. Next slide, please. So just to quickly review what palliative medicine is. It was basically defined as an approach which improves the quality of life of patients and their family members, and in a situation where there is a life-limiting illness. So this they thought would be possible by early diagnosis, treating, correct assessment of what is the reason and why, what is causing what symptom, and treating it well. And this included every domain of symptoms, which were physical, psychological, and spiritual as well. So that is the trajectory as we see. Initially it was thought to be only during the end of life care or during hospice care that palliative medicine came into picture, but slowly over the years there has been shift in the paradigm. Basically, it starts as soon as you diagnose a life-limiting illness, with waxing and waning of our reference or our inputs in patient care, because sometimes the symptoms might be more, sometimes they might be less. So our inputs might be more and less depending on how the patient is during the trajectory of the disease. And it slowly though it becomes more, especially when the disease directed treatment is not doing as good a job as it was previously doing, and our care now has shifted beyond death to bereavement care as well. Next slide, please. Again, to emphasize the integrative model of palliative care, where the disease management and our input go hand in hand, along with rehabilitation, if necessary survivorship, and if not, then end of life care and bereavement. Next slide, please. So there are a few competencies which are required for any palliative care physician and doctor who are practicing palliative medicine. So this actually came from a paper from Canada, where they introduced it as in the UG curriculum itself. So they are planning to kind of get it integrated from the get-go, so that they are aware of what needs might be present in the patients. So basically what they said was that any physician should be able to describe what a palliative approach of care is. Then they should be able to address and manage symptoms, specifically pain, and others like anxiety, fatigue, depression, anorexia, cachexia, etc. effectively. And not only just manage them, you get a thorough history of why it is happening, how it is occurring, and you should be able to do a good physical examination and order relevant investigations as well. Next slide, please. Then a physician should be able to participate in appropriate care of a patient, especially when he's dying, and also have time to address the issues of the family. So this includes, identifying the signs of dying, uh, having a good knowledge of what the common signs of natural dying process are, then how to empower the family, the patient himself, and the caregivers who are involved in the care of the patient when the death approaches, and even the after death care of the body of the patient should also be done. Next slide, please. Then, of course, the physician should be able to address the psychosocial and the spiritual needs of the patients. There are various tools to monitor and assess these. So they should be able to identify what these needs, what these tools are, and if there are any psychological or spiritual needs in the patient. End of life care decisions and the planning of end of life care should be it should be individualized not only to the patient, it is individualized to the institution as well, and to the state where you belong, because the ethical laws or legal framework might differ from places to places. So you should be able to help them get to those decisions, or uh, help them process what is happening and come to that decision without in kind of forcing your views and your perception onto them. Next slide, please. Then of course it's necessary to communicate effectively with the patient families and the other caregivers, and always to remember that all of the symptoms, all of the sufferings that the patient is going through is always multidimensional. It has, everything is interrelated. The physical symptoms would be related to the psychological issues that he's having, which will be in turn related to the spiritual needs that he's having, which can be affected because of the social surrounding that he's going through. So everything is almost always interrelated. So to get to kind of assess everything that is involved and try to manage it as rightly and to the best of your abilities. Next slide, please. And then along with all this, because we are doing so much, and because there are so many, and because we see so much of death and so much of suffering in all these patients, it's important to take care of ourselves as well. So we should be able to identify when we are reaching a state of a burnout, or a state where we won't be able to give our 100%. So it's necessary to take breaks or to engage in an activity that you enjoy yourself, so that you yourself keep mentally and physically well. Next slide, please. So I'm sure you must have seen this slide hundreds of times. So these are basically what they call the 4 roads to death. So what happens in graph A is what we all hope for, is like a sudden death where you do not realize what is happening and it just, poof, gone, so that's what we are hoping for, but it's quite rare and not very not very, not everyone is lucky enough, I would say, to have that kind of death. Type B is a terminal illness, specific more so this diagram pertains to oncology cases mostly, where because of the disease directed treatment that is going on, the disease or the health is stable, but once it starts deteriorating, it goes down the hill and eventually leads to death. Type C is you usually see in organ failures, where there is waxing and waning of the disease, as you can see. But every time there is a dip in the health, it never reaches the baseline that it was previously. So it is always going down the hill every time they have an exacerbation of their disease. And eventually, the end last admission that they have will lead to death. uh, Type, like the fourth graph is usually what we call old age or frailty, where there is a functional decline because of the aging process, and that is what leads to death. Next slide, please. So where is it likely to be benefiting? In almost everything. We have your chronic organ failures, we have chronic neurodegenerative diseases, we have advanced rheumatological diseases, oncology, of course, and even in patients who have had prolonged ICU stay with the multi-organ failures and which is not responding to treatment anymore. Next slide, please. So let me just give the question back to you. What do you think are the barriers to uh, palliative care in non-oncology as a whole? Why do you think it is so difficult? Please unmute and just feel free to give your inputs.
Always the focus is curative. It is the disease which is focused in non-oncology rather than the patient and the patient's needs.
Right. Anything else? You're absolutely correct. It's always, you always want to cure it. Can you just go one slide, like one click more? Ahead. No, aage. You're going backwards. Just go aage.
Just the down arrow.
Down arrow. Yeah. One more. Yeah. So we'll divide it into physicians' perspectives and what they feel are the barriers or why it is because of the physicians, and we'll have the caregiver or the patient barriers as well. So one, as you said, the physician always want to be curative, like it's always curative for him. So that's one thing. Anything else? The physician has to intervene in psychological, and yes, they of course have to. Not everyone can do it, but yes, they should do that. Yeah. Yes, so it's always cure. Next slide. The physicians feel that they're giving up on the patients. They feel that it's a personal failure, and there is a general lack of awareness about what palliative care is and what benefits palliative care can have in patient care. Next slide, please. So what are the caregiver perspective? What do you feel are the barriers from the caregivers or the patient sides that kind of hamper the referral to palliative care? This one is disease trajectory. They want everything to be done for their loved ones. There is guilt as of that they're not doing everything for the patient, so they feel that it's kind of their fault. Societal pressure, or as what do you say, like what will people say, what that's always a big thing, especially in our country where we care more about what other people will say than rather than what we feel as their relatives. Next slide, please. Yeah. So coming to the CNS diseases, we have dementias, we have our Parkinson's disease, we have brain injuries, traumatic brain injuries, and we have stroke. So all of them will have some component of palliative care that would be necessary in the long-term care that they have, especially the dementias and the neurodegenerative diseases. Next slide, please. So the common symptoms in the nervous system would be seizures. You have your paresis or plasias, as depending on how many limbs are affected. You will have a lot of dystonia, hypertonia or hyper or hypotonia. You'll have dysphasias, you'll have aphasias. So these are the commonest symptoms that would be present in the central nervous systems. Next slide, please. So management wise, you need to remember that rehabilitation works for all the diseases. It's not just only for nervous system or cardiorespiratory, or it goes across the board in all the organ failure. So rehabilitative measures would be important and would help manage symptoms better. So always remember, if it's not given, give a physiotherapy reference. They do wonders in helping the patients. Dystonias in hypertonia specifically, even some component of dysphasias, muscle relaxation works wonders. Like it kind of helps you get rid of the pain also because of the um, contractures or because of the continuous spasms in the muscles. And overall they give a sense of relaxation to the patient. So wherever necessary, please use muscle relaxants as necessary. Analgesia for the pain overall would be a good thing to start if there is pain in the patient. So and by analgesics, I don't just mean NSAIDs or paracetamol. I mean opioids as well. So if you feel that the pain would be more more or better relieved with an opioid, please feel free to prescribe opioid, and don't be kind of stuck in the thought that it is only for cancer pain. It is helpful across all types of pains, and you will be giving it in a monitored dose, so there is no need for you to be scared about the overt side effects that we have with opioids. Anti-epileptics as and when needed. NG or peg feeding. So there are different schools of thoughts about whether an NG tube or peg tube should be inserted for a patient. So what are your thoughts? Like in your day-to-day practice, do you actively do this? Have you come across patients who are, palliative in nature but require NG feed or NG tube insertion? What have you done with them?
Ma'am, I had a patient with advanced Parkinson's disease,
Okay.
and patient was coming repeatedly with respiratory infections. It was basically because of microaspirations. Patient was repeatedly having aspirations and developing pneumonia, repeated ICU admissions. So first admission itself, we had counseled the patient party regarding nasogastric feeding, but patient was conscious. Of course, advanced stage bed bound, but patient was conscious, could talk to the relatives. They were finding it very difficult to accept that patient requires NG tube. By third admission, of course, we could counsel them, and patient is now on NG feed and doing well. After that, there were no admissions for pneumonia, microaspiration related.
Okay.
But it is
Great.
very difficult to convince them initially. It was difficult
Yes.
for us to convince them.
Yes, and it kind of has a social stigma attached to it as well. That there's a tube through the nose. People stare at you, and so that kind of makes it awkward. Not only for the patient, like I mean, I'm sure the patient would not be aware of it by the time he got the tube inserted, but for the family members, they like people ask a lot of questions when something is different. So it carries a stigma to it as well. So the schools of thought for peg insertion is, as you rightly said, if the prognosis is in months to years, it is better to put in an NG tube or a peg tube. Peg, if it's a very long term, then a peg would be preferable because it does not affect the gastroesophageal sphincter. Like it, because in nasogastric tube keeps it open. So if there is a heavy bout of coughing or vomitus, there is still a chance for aspiration to occur. So oh, that's what they say. Like it's debatable. Like I have seen patients who are well managed on NG tube for months together, and I've on the other side, I've seen patients with peg insertion who have come with aspiration as well. So it's like depends on patient to patient, but over the research says that if it's a long term, then a peg tube is preferable to a NG2. But again, it depends upon the finances and whether the patient is agreeing, and the if it's available in the nearby area, because you don't want to send the patient just for a peg insertion to a far away city. That will be like besides the point. Speech aids. So especially for people with aphasias and locked-in syndromes and everything, speech aids can sometimes be very important. Speech aids can be as simple as asking them direct yes and no questions, where yes is one blink and no is two blinks or something like that, or movement of the eye. Move it to the right if it's yes, move it to the left if it's no. It's as simple as that. Or you have various other electronic speech aids where, you know, they have pointers which they point to the letter so that they can spell out whatever is whatever they want to say. But again, this depends on whether you there is availability of those kids in the institute where you are working, and or if not, the institute nearby area where you're working. So the simplest one is direct asking direct questions where you can just get an yes and no answer, so that you can just speak, communicate with them. Next slide, please. Coming to the cardiovascular diseases, so basically they are your heart failure, your congenital heart diseases, and Eisenmengerization. Next slide, please. So the commonest symptoms here are chest pain and breathlessness. Palpitations is heavy, which can be perceived as a state of anxiety or anxious nature. There is peripheral edema. There is a lot of cough, sometimes associated with hemoptysis, fatigue, and sleep disturbances. Next slide, please. As I said, rehabilitative measures across the board, so in all the diseases possible. Opioids are generally the first line for chest pain, even in myocardial infarction. So please feel free to give opioids, especially if there is heart failure. It works wonders. It will help with the breathlessness as well. So opioids can do wonders here. Diuretics, again, to, you know, kind of decrease the preload on the heart, and it will help with the peripheral edema as well. So diuretics as and when needed. Beta blockers, again, a debatable question. If there is a lot of palpitations, then beta blockers work to just reduce the heart rate. But again, you know, you need to balance it off with whether it will be counterproductive if given in such patients. Oxygen support, oxygen is also a drug, you need to remember that. So give it only when it's necessary. Do not give it just for the sake, you know, just because the patient is feeling breathless but the saturation is normal, do not start him or her on oxygen. There are other non pharmacological measures. Can anyone tell me what are the non pharmacological measures for breathlessness? What can you do apart from opioids and diuretics and other oxygen? Anything else that you can do which does not involve any drug for breathlessness? Propped up
Fan therapy,
chest physio prone. Sorry,
maybe fan therapy,
what therapy? I'm sorry, I did not get you.
fan
Fan therapy. Yes, yes, that is true. Bronchodilators, again, it's a medicine. Yeah. So handheld fan, you have your propped up position, you have your chest physiotherapy, you have certain, you know, if pursed lip breathing sometimes help with um, managing the breathlessness. Reassurance, yes. So getting, if there is an distress or a psychological issue that is causing anxiety which is leading to increased breathlessness, then yes, dealing with that. Very good, excellent. Assure the patient that he's fine, ask deep breaths, yes. And breathing into the bag, yes, that is another good one. And you know, you can help by, you know, breathing in with them, like take a deep breath, I'll also take it with you, and then just slowly breathe them out. So that kind of helps and reassures them as well. Relaxation techniques as well. Yes, great, excellent. Next slide, please. Coming to the respiratory diseases, so we have your end stage COPD and ILD. You have your cor pulmonary and you have pulmonary embolism, which also sometimes is very irritable. Next slide, please. Again, the cardiovascular and respiratory symptoms overlap. So you have your breathlessness, weight loss, fatigue. You'll have delirium here. You'll have a lot of palpitations and headache. Next slide, please. So can anyone tell me what is the mechanism by which opioids help in breathlessness? Anyone? Has it been taught to you? If it's not, then I'll not go into it. If you have been, then anything else? decreases the respiratory drive. Okay. So basically what it does is it also decreases the sensation of breathlessness that goes for perception. So it kind of abuts the sensation sensory overdrive that I mean, so sometimes what happens is that when you look at the patient, you don't feel that he's any better, he or she is any better, like they're going up and down, they're gasping, but the perception that the patient has is not there. So the patient will not feel that he's breathless, so that perception is gone. So that is a main thing that it causes. Okay, diuretics, again, it will help if there is any pulmonary edema or anything of that sort, it will kind of reduce the breathlessness. And studies have suggested in few patients, nebulization with furosemide also helps in breathlessness. Not all the patients, a certain number of patients, it has helped. So if it helps in your patients, well and good, that can be another modality of management. In acetylcysteine, again, especially if there is a lot of thick mucoid secretions, which is not coming out, or the patient is not able to cough it out very well, an acetyl system will help thin it down and make it easier for chest physiotherapist or chest physiotherapy exercises to kind of expectorate it out after the nebulization. Oxygen support as and when needed, as already mentioned. Antipsychotics for delirium might become necessary, and should be given as and when needed. So usually haloperidol, or you have your olanzapine as well, which helps very nicely. Steroids, again, whenever required, should be given liberally, and it might become necessary for you to keep it, like usually you taper off your steroids after, let's say, 2 weeks or 3 weeks. So sometimes in this patient, it might become necessary to keep them on a very low dose of opioids throughout, just so that they maintain their functionality. But not in all patients. It is as and when needed by the patients. Sometimes in respiratory cases, it might happen that it has stopped responding to steroids altogether. So you'll have to manage how to uh, how to go about it, like what other options are there instead of steroids to help reduce the breathlessness. Next slide, please. Coming to the hepatobiliary diseases, we have our end stage liver diseases or liver failure. Next slide, please. The main symptoms here are nausea, vomiting, fatigue, weight loss, and all the signs of liver failure. Next slide, please. Can anyone tell me the rehabilitative measures we are not going into, but can anyone tell me what will be the antiemetic of choice in a patient with liver failure? And why? Anyone? What would you generally give? Metoclopramide. Okay, why? So usually anything that crosses the blood-brain barrier would work. So metoclopramide, yes, it should work. The best one would be ondansetron. Just basically, gastric emptying is not the mechanism you're looking for. Basically, here what happens is that you have your rising bilirubin and everything. So basically, everything that is the cause of nausea is your central cause. It's not peripheral. So you want anything that acts centrally will work wonders. So in ondansetron would work better, would work best. Metoclopramide also You have your haloperidol, which it's a dopamine antagonist, which would work wonders in nausea and vomiting in such cases. Okay. I've written sertraline there. Why? What do you think I've written it for? What is one thing that is very irritant once your bile salts have increased? Very irritating. Like, very irritating symptom.
Itching.
Itching.
Yes, exactly. So, that's a very irritating symptom, and it's not just, just one hand or, the upper body. It's the whole body itches, and it's throughout the day. There is no, like, evening rise of symptom or anything. It's just throughout the day. It's so bad that there are, excoriation marks all over the body. There is, decreased sleep, and it's just very, very irritating. So sertraline is actually the first line of management for pruritus and liver failure, and it works wonders. Even a small dose of 12.12 mg would work wonders. I think the tablet comes in 25 mg formulations. I'm not sure if the lesser one comes, but you can start off with a half tablet as well, and it works wonders. Just after a day or so, they are like, the itching is gone now. There is no itching. So it works that wonderfully. So always keep that in mind. Yeah. Second line is dapsone here, and the third line is your ondansetron. Laxative. Which laxative would you prefer in lactulose? Yes. What is the mechanism? Anyone? Yes, it reduces the ammonia absorption, so that's how it decreases. It's even given in your encephalopathies, hepatic encephalopathies. So, and supportive measures. By supportive measures, here I mean that, there might be ascites formation, so ascitic tapping as and when required, antibiotics as and when required. You might have to do limb physiotherapy because there's a lot of pedal edema in such cases. So as and when required, you might need to give additional supportive measures to these patients. Next slide, please. Kidney diseases. So end stage kidney diseases, usually the commonest causes is hypertension, diabetes, and glomerulonephritis. Next slide, please. Again, the symptoms overlap with that of liver failure. So you have your nausea, vomiting, you have decreased appetite, fatigue, decreased urine output. Then because of the decreased urine output, you have your symptoms of fluid overload, that is edema, chest pain, breathlessness, headache. You again have pruritus, muscle twitches and cramps, and sleep disturbances. Next slide, please. So again, the antiemetic of choice here again would be anything centrally acting, right? The cause is different. Here it is the urea that is rising, which will cause the nausea or the vomiting. But anything that acts centrally would work here as well. What is the antipruritic agent of choice here? Not sertraline. Sertraline comes as third line, if I'm not mistaken here. So what is the, anyone want to just, give it a shot? So no. Okay, so it's basically phototherapy. Atarax, not so well. Phototherapy, UVB light helps in uremia-induced pruritus, or local application of capsaicin. That's what's, UV therapy. And capsaicin, local application of capsaicin helps in uremic pruritus. Naltrexone will also sometimes help. Laxative again would be lactulose, and supportive measures as and when required. Next slide, please. I think so I just wanted to focus on breathlessness because it would come in almost all the diseases that we look at. And this is, I'm sure you must know this, this is the breathing, thinking, functioning model of breathlessness. So what it suggests is that because of the breathing patterns, because of the thoughts, and because of our functionality, everything has a reason for increased breathlessness. So in breathing pattern, because there is inefficient breathing, there is increased work of breathing, which leads to increased uh, respiratory rate and use of accessory muscle, which leads to breathlessness. Thinking, because of the lot of anxiety or um, intrusive thoughts about dying, misconceptions that we have about our disease, and a lot of attention given to the symptoms that is occurring and leading to increased anxiety regarding that. It leads to distress and panicky state, which again leads to breathlessness. Functionality, what they say is because of the disease and the thoughts, you kind of feel sick, so you are bedbound or you have reduced activity, you self isolate yourself, and are more dependent on others for your daily activity. What this leads to is deconditioning of the muscles of your body, which leads to breathlessness. So when you have a patient with breathlessness, always remember all 3 points and try to manage everything so that they are functionally more independent and the symptom is better managed. Next slide, please. Uh, End of life care. Next slide, please. So this was the initial Indian Society of Critical Care Medicine pathway about how end of life care should be. Simplified version, next slide, please, is basically whenever a patient comes to you with an prognostic uncertainty, uh, which is a physician's assessment, not what the patients are saying. You kind of ascertain that okay, there is kind of he does not look good, and maybe the treatment won't work further, and you consult all the treating physicians. Like supposing it's a respiratory case, but there is a component of like even the cardio is involved and even the nephro is involved, get consensus from everyone who are involved in the treatment, and you still establish that, and you come to a conclusion that yes, there is no, like the prognosis is poor and the patient is not going to benefit from further treatment. You have an honest open discussion with the patient slash relative, and you establish what the goals of care are. And after doing that, if the patient is on any life sustaining treatment, which includes not only ventilator, but it will include dialysis as well. So if there is an option, you can withhold or withdraw from it, and you give comfort care or good supportive care to the patient. Next slide. And please document everything. Like you have to document everything. And it's not written in stone. So the patient always has an option to change his mind again. So if they today they feel okay, don't go ahead with the treatment, but the next day they are like, please give all the treatment possible, then give all the treatment possible, because it's their choice after all, right? So the road ahead, well, it's kind of a very confusing road ahead, especially in non-oncology, where the trajectory itself makes it so confusing as to when to introduce palliative care for that patient. So it's a twisted road, as you can see, and a long road ahead. But hopefully with everyone joining in to make it more accessible across the country, let's hope for a better future for the patients. Next slide, please. Thank you so much. Any questions, any comments, any inputs, please feel free to give them.
Thank you, Dr. Rutula, for that comprehensive presentation. Yes, we do have a couple of questions coming up. Would you like me to get it read or?
Yeah, I'll read them. Thank you. Rehabilitative measures. So in cardiovascular and respiratory, usually chest physio works wonders for as a rehabilitative measure. Sometimes even doing spirometry helps, especially if they've just recently had their pleural tapping done, or something like that, or they have some procedure done. That helps. Rehabilitative measures will also include your propped up position, or positioning rather, not just propped up. Just positioning of the patient is also an rehabilitative measure. So the chest physiotherapists do it very well. Rehabilitative measures will also include your diet. It will also include all the accessory supportive treatments that we give. uh, what what's the difference between withholding and withdrawing of treatment? So withholding is before initiating the treatment you decide not to give it. That is withholding a life sustaining treatment. Withdrawing a treatment is when the patient is already on a life sustaining treatment. For example, the patient is already on a ventilator, you decide to stop the ventilator, you withdraw the treatment. So that is withdrawing of treatment. uh, Rehabilitative measures, any specific thing about rehabilitative measures, or is did your queries get answered in the previous one? What is the dose of opioids for breathlessness? So usually for breathlessness, morphine is preferred as the opioid of choice. If you're initiating opioids in patients for breathlessness in an opioid naive patient, you might start it as low as 2.5 mg twice a day or thrice a day. It depends on how much the patient is tolerating, but you can start it as small as that, and you can go up to how much ever the patient needs. If it's an opioid tolerant patient, which means that he's received any sort of opioids for more than 24 hours, then you can start off with a bit of a higher dose as well. Treatment options for pruritus and hepatobiliary are second line. So first line is sertraline, second line is your rifampicin and dapsone, third line is your naltrexone and ondansetron. Will we give morphine in low dose for breathlessness? Yes, we can give morphine in breathlessness, and it works very nicely for this. As I said, 2.5 in opioid knife, you can go start off with 5 to 10 mg for an opioid tolerant patient. Any role in morphine along with so usually diuretic should help with pulmonary edema in the sense that it should resolve the breathlessness. If it is not, then what happens is we call it as a refractory breathlessness, and opioids are used for refractory breathlessness. So yes, you can give morphine if it's, and you can even give it as like an supportive treatment as well, that till the diuretic starts functioning well, you can start him on morphine. But again, that depends upon how much is the severity of breathlessness as well. Any other questions? So fatigability, not a lot of drugs are there for fatigability. Steroids do help to a certain level, but again, it's not a long-term option. For fatigue, it's usually your light exercises, eating small meals frequently so that they don't feel overtly full and kind of tired all the time, making sure that they are distracted from the thoughts of their disease, so that because mental fatigue becomes a component of why they are fatigued all over as well. So it's more of like your physical movement, physical exercises, your psychological measures that help in fatigability. Not a lot of drugs are there. Yes, wherever it is useful, there you can use nebulizers. So If you feel that the reason for breathlessness is bronchoconstriction, you can give nebulization with bronchodilators. As I said, the nebulization with furosemide has helped in certain cases of breathlessness, so you can try that in patients as well. Nebulization with N-acetyl system also sometimes helps, especially in getting the secretions out so that they can breathe easy. So yes, wherever you feel that it will be useful, you can use nebulization. Any other questions?
Ma'am, with your permission, we can move on to the case presentation if there are no other pressing questions. Meanwhile, participants can post their queries in the chat box as we move along if you have any more things to clarify. Adu, can we have this? Dr. Anjali?
Yes. Can you hear me?
Yes, we can.
Yeah. So it was a case of 75-year-old male who presented with chronic obstructive pulmonary disease, an acute exacerbation, and this was during my internship. So it's not a recent case. Yeah. Next slide, please. So he came with a complaint of fever for 3 days, cough for 3 days, and breathlessness since 1 day. History of illness was that he was in usual state of his health 3 days back, following which he developed fever along with the cough, and it was productive with yellowish sputum, non-blood stains, foul smelling. And since last night, he experienced an increase in breathlessness, which was progressive in nature. There was no history of chest pain, palpitations, nausea, or vomiting. And his past history included 5 times admission to the hospital due to breathlessness in the one last year itself. So he was advised on home treatment with the BiPAP, and he was diagnosed with COPD 20 years back, and he's also a hypertensive patient. Next slide, please. So his examination included, he was conscious, he had a cachectic appearance, and his vitals were within normal limit except for the saturation, which was very low, and he had a temperature. Orthopnea was present, and systemic examination included. On inspection, there was use of accessory muscles. Trachea appeared to be central, and chest wall moved equally bilaterally, and palpation included trachea was central. Chest expansion was only 1.5 centimeter. AP diameter was 27. Transverse was 23. Percussion resonant over all the lung fields except for the right lower lobe where it was hyperresonant, and auscultation. He had bilateral V's with decreased breath sound in right lower lobe and crepitations in left lower lobe and right middle lobe. Other systemic examination was within normal limit. This was his X-ray where he had the right lower lobe translucency and patches all over. Next slide. Yeah. So the treatment included, he was started immediately on the on oxygen at 15 liters per minute with a face mask, and his saturation improved from 76% to 82%. And he was given nebulization with bronchodilators, salbutamol and corticosteroids. Even oral morphine was given, and later NIV was started and saturation was maintained at 86%. Cough expectorants, antibiotics was given as adjuvants. Investigation, all routine investigations like CBC, RFT, LFT, PSI, chest X-ray, ABG analysis, all were done. So psychosocial aspects. He was a widower with 2 children, and he had a smoking history of 25 pack years, with having stopped 5 years back. He worked as a manual laborer till 55 years, after which he was diagnosed with COPD and his condition deteriorated and he could not go for job. And in the past year, his condition has even deteriorated from walking for a lot less distance to mostly being bedbound and having difficulty even going to bathroom. And his children were not financially well settled, so it was difficult for him to be dependent on them also, and he felt guilty about it. He disliked being a burden to them and felt inadequate and uncared for. So medications, he was advised on inhalers as a regular use, bronchodilators and corticosteroids. Antibiotics was given to treat his fever. Antibiotics was given for infection, and he was already on hypertension, antihypertensive, and he was advised again to continue BiPAP at home. So the main concern for the patient was regarding his breathlessness and increased number of episodes that was occurring in the past 1 year, especially 5 episodes. He had hospital admissions, and this was causing burden on his family, both financially and emotionally. And other factor was the lack of emotional support for him, because his children were not settled well, and he is a widower, so he was not getting the adequate amount of attention. And the patient was in a debilitating condition, which with the risk of demise at any point of time. So as summary, he was an elderly male of 75 years, presented with breathlessness that started 1 day before, which was progressive. He had a fever and cough production. And he was already a known case of COPD who was on BiPAP treatment at home. In the past year, with 5 similar episodes, he was hospitalized, and his smoking history included 25 pack years, financially dependent on his children. And on arrival to hospital, he was immediately started on oxygen via face mask, and vitals were being recorded. Oxygen saturation improved after giving oxygen. And he was continued on oxygen, given embolization, morphine to relieve his breathlessness. Relevant investigation and physical examinations were done, and chest X-ray showed patchy lobar infiltrates and right lobe translucency. Treatment included antibiotics, antipyretics, and cough expectorants along with oxygen. So the discussion point is, how can we inculcate the use of palliative care in advanced COPD cases? How can we manage this patient by addressing his social well-being also? And how to maximize the public awareness regarding the use of conservative management rather than invasive treatment modalities in COPD? And how to involve the patient's family regarding his situation so as to increase their involvement in his life.
Thank you, Dr. Anjali. Now it is open to the participants. So you can express your views, how we can take up the questions one by one. Since we do not have a facilitator joining for the session today, unfortunately, I think Dr. Rutula will be the one directly guiding us through the discussion.
Yeah, sure thing. So it's open to the participants, and I would like to hear your thoughts about how to do this. So how can we inculcate the use of palliative care in advanced COPD? Any thoughts? Do you see a lot of COPD patients in your setup?
I say?
Yes.
So during my internship, most of the cases that were admitted in the medicine ward were mostly of COPD only. So
Okay.
that was a lot of cases of that.
Right. So did you, like you mentioned that they used morphine for breathlessness here?
Yes.
A routine practice where you work?
No. It was not a routine practice. It was like once only I've seen one faculty who was he was a
Okay.
professor, only he used it, I've seen.
Okay. So, but there was no formal, was there a
No.
palliative care team in the hospital?
No.
Okay. So, yeah. So, do you, any comments on how you would want there to be a, like, how would you want palliative care team to be involved in the care of the patient?
I would like to actually know when should we diagnose the patient as an advanced COPD with, the risk of death at any time. How to differentiate it from the normal COPD cases, which also like 20 years COPD history is quite common, 10 years, 15 years. So how to exactly distinguish between those two so that we know where we should stop the treatment and go mostly for the counseling, not stop the treatment, but mostly in a way of counseling.
So what I've, kind of gathered from my discussions with the pulmonologist in my hospital is that basically there's a very thin line between moderate COPD and advanced COPD. It basically depends on your functionality, that how much, your 6-minute walk test and your, your, what do you say, spirometric findings like
PFT.
PFT findings and everything. So that is what it depends on. And given the fact that this gentleman, like your case specifically, he had 5 admissions in the last 1 year.
Yeah.
That itself gives the red flags that, maybe a palliative care consult should have been done. Like, just given the fact that it's kind of deteriorating pretty quickly now with repeated admissions and hospitalizations required. And it's not necessary that the patient suddenly becomes like just for palliative care. The
No.
disease directed treatment can go side by side along with symptom management as well. So, and here what we do is, and as you must have already gathered, it's not just the physical symptoms that we are looking after. So it's your psychological as well as your spiritual as well as your social issues that are kind of addressed throughout the throughout the consults that we give. Now what happens is that sometimes because of a consult, um, the rate of hospitalization also reduces, in the sense that they themselves do not want to get admitted, or even if they are admitted, they do not want anything that is very invasive to be done to them. So they are like, "Nahi, theek hai, do not shift us to the ICU, do not shift us to, do not do this, do not do." So they're very clear about what they want to do and what they don't want to do, because they know what is happening and what eventually will it lead to. So that kind of becomes clear. Now how to get it inculcated in the practice, that actually depends upon your, the, as you said, the professor or the pulmonologists who are there in the, so creating an awareness amongst them first would be a good way to just start initiating it. And they are like, at least you might even start off with like, at least give us the end of life patients, who with with COPD or with ILD or whatever, at least start sending them. So once they see that you're doing a good job with them, then maybe they'll refer the patients to you one step before that. So you get patients who like that. And you can't suddenly ask them to just send you like a moderate COPD patient to, just because he has a lot of symptoms. They're like, "Yeah, I can manage the symptoms as well." That's their perception, and that's correct in a way, that they can manage the symptoms well. So kind of and no one will refer patients to you unless they see that you're doing a good job. So start wherever you can, and then expand your horizons as you go, so that they see that you're doing a good job and that everything happens well when you are involved in it. So they kind of like, "हाँ, ये बात कर लेगी, ये कर लेगी सब, my headache is gone." So and it I mean, sometimes you feel like, "Arey, we are not counselors, or we are not social workers to do all this thing." And you might feel like, why did we become doctors if we had to do something like that? But then at least you start somewhere and then kind of do what you want to do. Let's just read the way. Yes, I think awareness among the patients and patient education helps. What usually happens is, whenever any chronic diseases diagnosed, be it COPD, be it ILD, be it cardiac failure, be it your chronic kidney disease, what the patient, what the physicians say is that, "ये दवाई लो, ठीक हो जाओगे," which roughly means that you just take the medicine and you'll get better. So now what the lay person understands by this is that I will be cured, when that actually is not the point, or not the fact. Like, that's not the reality. What you're doing is kind of just giving like a supportive measure to whichever organ you're treating, and that's why you feel better. It's not actually treating the underlying disease. You're just making it easier to function around whatever damage has already occurred. So you need to, and so that's where patient education comes in play. At the first diagnosis or at the time of diagnosis, if you tell them that this is a chronic disease, like how they say about diabetes or hypertension, now they know that lifelong I have to take medicines for that. So something like that, when you tell them that this is a chronic disease and we will give you things, it will alleviate the problems that are occurring, but there is a chance that you deteriorate or your lung gets worse or your kidneys get worse. So what happens is that the patient realizes how it's going to go down, and not say like कि, अरे आपने तो बोला था ठीक हो जाओगे and I've become worse now. So that doesn't happen. So patient education is actually very important. Role of chest physio and an education on handling acute exacerbation. So chest, I agree with you. Chest physiotherapy and chest rehabilitation or pulmonary rehabilitation, that as it is called, is very important, and it kind of helps in improving the functionality of the patients. So it's a good practice to refer them to a pulmonary rehabilitation wherever you can, and just help them functionality, so even the symptom burdens kind of reduces when rehabilitation is started. The need for course of illness and how it ends in physical, yes, agreed. Chest physiotherapy, psychological counseling, financial aid measures, and low dose morphine. Okay, correct. I feel counseling should happen on every consultation. The symptom severity itself is a red flag for deterioration. Usually they become bedbound and other complications arise from it. I agree with you completely. Mostly, so you can have like a checklist for palliative care references made for your institution or for your hospital where you're working. And like if this is there, then refer. If this is there, then refer. Kind of list of all the diseases, like advanced COPD or advanced ILD requiring hospitalization of more than 4 times in 6 months, let's say, or for a year, in a year, or ICU stay of more than 20 days with multi-organ failures, and then you have your chronic rheumatological diseases not responding, advanced malignancy, all these, like just have like a checklist of them. Then you can have like another small like part A, part B. Part B will have like age more than 65, or something like that, like multiple comorbidities or whatever. Like so, 2 of the part B, but any one of part A will also work. So they should have like a palliative care reference done from the get-go, so that everything is managed better. So you can create something like that, just to help create awareness among the physicians as well, and not just the patient. We are talking about the physicians as well, because a lot of physicians, a lot of medical faculty are not aware about what palliative care is and how it will help them give better care for their patients. Good pulmonary rehabilitation, deteriorating factors and advanced debilitating symptoms counseling. Yes, I agree. Encourage incentive spirometry, deep breathing exercise at home as a routine. Correct. Avoid trigger factors in and around the patients. The patient is not doing well in spite of being optimally treated for COPD, palliative care. Yes. Repeated infections can be prevented by vaccine. Yeah, up to a certain level, not always. It will not work, and it will not work for all the opportunistic and pathogens. So, but I agree, wherever it is possible to vaccinate them, just to uh, avoid getting those infections. Any other points that you feel that I've missed out or you want to add? Okay, coming to the next question. How do we manage this patient by addressing his social well-being? How would you do that? He's a 75-year-old gentleman. Any thoughts? Okay, now coming to any social well-being, how would you maintain, let's say, your social well-being? What do you generally do for your own in your own social environment?
For his, to engage in some activity so that one does not think more about what is happening in the reality, so that we keep less thinking about the problems.
Yeah, so basically any distractions, any distraction measures would help. So one is that he could you can encourage the neighbors or the relatives to come and visit him so that he is not feeling lonely. If there are any for him specifically, it might be difficult to kind of engage in social activities, like you have like your religious gatherings, you have your festivals that you celebrate. It might be difficult for that for him to do it particularly, but these are certain things that you can help kind of get him more socially active in a sense, so that he is not alone, or he does not feel that he's been isolated from the rest of the people in his social group. NGO supports, yes, so certain NGOs, specifically those who work for geriatric population, they kind of give their time. So what they have is, I think it's called a time bank, where the volunteers of the NGO give in their time. They slot in their time. Like I can give 3 hours, I can give 5 hours, I can give a day or whatever. So they slot in their times. And what these NGOs then do is, in patients who require or who are staying alone but require a companion, they just kind of go in as their caretaker and spend 3 hours, 4 hours, whatever they can give to them, and it's kind of slotted in their account that you've given 3 hours of your day. I don't know what incentives they get for doing that. I'm not aware of the whole thing, but they do have something called as time banks in certain NGOs. So yes, um I think it depends on what NGOs you have in the area, and like you'll have to find out if there are any NGOs specifically working for old age people or for pediatrics, or they have certain specific NGOs, like they have oncology specific, they have COPD specific, they have HIV specific. So they have specific NGOs. So you'll just have to find out which one are there in your area. Social well-being has to happen by involving the nearest, yes, so involving the family and the friends of the treating patients. Yes, so what social worker does is she gets all these points in a very concrete and in depth of all the issues that the patient is having, and they might be the facilitators to kind of connect the family members or the relatives with the patient if that is the cause of social distress, or with the friends as well. So they can be the facilitator. Why don't we have like a family meeting and we'll just talk it out? She can be the initiator of the whole discussion, and then she takes a back step and they just discuss it among themselves with you being there as a moderator or a facilitator. Sometimes, luckily, if any NGO supports in free counseling, that will help in being socially engaged at homes, and many times, yes. So, yes, NGOs work, social workers work, volunteers work. So, sometimes even the relatives of patients who have passed away because of certain diseases also volunteer for helping out for other patients. So they have their own NGOs as well, just to you know, help out the patients who are suffering from the disease that their loved one died of. So you can find out about these as well. Public awareness, the World COPD Day, which falls on November this year, has been utilized to create awareness on its prevention supportive. Yes, so and you can conduct such public awareness. I wouldn't say campaign, but just like in your locality, in the society that you live in, just getting all your friends or someone to just kind of have a awareness camp in your society, or in your locality, if that's just to involve a larger larger population. Or you can, for certain diseases, you can even go to schools and create awareness among them. Or your some non-medico friends that you have, and she or he works in an office, you can go to their office and create have these awareness camps, so they get aware and they create more awareness, and they refer patients whoever require your help from them. So that's how you can create awareness amongst the population in general. Maximize public awareness regarding the use of conservative management rather than invasive treatment modalities in COPD. So I think this also depends upon the doctor, like the treating physician as well. Not in the sense that you never have to use invasive modalities, but in the sense that he should be able to put his foot down where it is necessary and where it won't be of any help. So obviously you would want the patient to come out of the exacerbation. It's not that you're like, yeah, theek hai, COPD hai, chronic hai, he has to die at a point, why bother? So it's not that. So you obviously want to try till the last moment. But even when you're trying till the last moment, you should be then comfortable with withdrawing care as well, where you say that this is, look, we've tried for 3 days, it's not working, I think it's time to stop it. So not to prolong their suffering and distress that they are having because of the invasive modalities as well. So there's a fine line where like supposing in this gentleman where who in whom it was like the 6th admission, I'm assuming in that year, then you can say that okay, you know what, we'll not go beyond BiPAP. So that can be clear. BiPAP pe ho raha hai, nahi ho raha hai, then we will stop there and we'll see what happens and we'll accept what naturally happens. But in a patient who is like having the first episode in the year of exacerbation and he requires ventilation, you will obviously, and he's having advanced COPD, no doubt about it. But you will not say that okay, advanced COPD, so I'm not going to ventilate you. So there's a kind of a patient to patient basis upon patient to patient differences upon which you will decide whether to go for invasive or not go for invasive. But even if you go for invasive, you should have that confidence and ability to put your foot down when it is becoming an unnecessary treatment modality. So to create awareness about that as well, and to make it a normal thing rather, because it becomes like a huge medical legally, it'll be like a huge issue and all that. So the physician should be made aware that it is actually in the benefit of the patient that you're doing this, like you're doing more harm than benefit the patient if you continue that management. So, and public awareness, I think again, if you create public awareness about palliative care, automatically they go more for conservative than for invasive. But
One
again,
doubt.
yeah.
Ma'am, at this point, for his social well-being, can we refer him to a hospice, because at least he'll be surrounded by people who will be caring for him?
Yeah, you can refer them to hospice, but they should be well equipped to handle those patients. Like even the hospice should be the one where you can handle the patient better, because I've had certain patients who we had referred to an hospice and they were like ki wahan pe sab marte hai, we are not staying there. So people just die there, we are not going to stay there. So they have that phobia as well. So they should be kind of like an environment where they are comfortable. So what generally I do is like, please go and see the facility. If you feel that it is okay, then shift your patient there. Otherwise, please do not shift. And that is the best thing that I can. But I agree with you that, when you see other patients who are in a similar situation, your anxiety kind of lessens, but it can have like the opposite effect as well. So kind of just let them take the decision. Do not directly send them off there. Tell them to go and visit the facility once and see how it's going. Yeah.
No, one more doubt.
Yeah.
Like how to put this into curriculum where non-cancer also gets a palliative care kind of treatment, because in our curriculum, till the batch I joined, there was no information regarding the palliative care, especially in a non-cancer, because in cancer, people are aware, people know that ultimately it might end in death, and they are more comfortable accepting that palliative care. But in non-cancer illnesses, to diagnose it, to recognize when it became a palliative care and how to manage that situation and make the people, relatives along with, because all the physicians are not, I mean,
I agree
what
with
I've seen.
you.
So
I am
it's not.
suffering with the same problem actually. So I completely agree with you that oncology, it is like taken for granted that the patient will eventually die. So the acceptance for palliative care is more in in oncology than in non-oncology. What happens is that, as I said, start wherever you can. Like start off with one patient if that is what you're getting. Manage it well. If they see that you're managing it well, I'm sure that they will want to refer it to you, because they have hundreds of patients, you have none. So so they kind of want to kind of reduce their work burden as well. So it starts off with that, in a sense that they are kind of batting it off, as we call it here in Pune. Patient bat kar rahe, like they're just sending them off because they don't want to manage it. That's what basically it does. But start off wherever you can. What you can do is that you can department wise, if you are that enthusiastic, what you can do is you can go to departments and then give them a small presentation regarding that department, why it is important to give reference to palliative care and how we can help in managing your patients. And we are not, and specify that we are not going to overtake the patient, like it's still going to be your patient, we are just going to give an added layer of support and care for the patient so that he is well and good and manages it better. So that way. And I'm mostly at the professor levels, they are all kind of aware of how things are and they are very welcoming. It's the junior ones that are kind of reluctant to refer patients or give references and all that. So it's how you tackle them that becomes a issue. But you can actually go and department wise, like pulmonology, cardio, nephro, hepatobiliary, or rather gastro. You just go there and kind of give it like a 5-minute presentation also will work. Like just think, yeah, we'll help in this, and just sort of like a very dramatic, like in your face, like it's very attractive and all that, and helps, generally helps. The references are still pretty low and usually at end of life, but it's a start, basically. Discussing with the family members and making them aware about the current emotional requirement of the patient may help in getting them involved. Not always. Like I agree with you that it should get them involved, but not always. People are like, "ठीक है ना, तो मेरे भी इतने problems है, मैं क्या करूँ?" Like they are busy with their own work and all that. So how to get them involved becomes a tricky thing. But making them aware about their emotional requirement is a good start. And they sometimes the family members might be the source of distress as well, that because of their behavior or whatever, we don't know half of their family issues that are present in the family. So it's kind of a very tricky thing how to manage that. So, and it's always best not to get too involved in the family issues, like financial bolo, yeah, they have some fight amongst themselves or they have some property issues or something. So it's better to let the social worker assess what is going on and kind of just tell that this has this issue, this has that issue. If you want, we'll sit together and we'll talk it out and get. So there should be one person present just to kind of monitor everything, but do not get too involved in trying to solve that problem. Just kind of let them vent it out. That is what you should do. Sometimes the patient's family is unaware of the emotional issue because many patients fail to open. I completely agree with you on this, especially the elderlies. They feel that they are a burden to the younger generation and they do not want to overburden them more, because generally they were the ones who were taking care of the family, and now it's the other way around. So they have that guilt as well, that because of me they are unable to do this and that and blah blah, financial, everything involved. So yes, they are here, as you said, in this situation, then getting the relatives involved and just kind of easing out ki, no, you're not a burden and you're not this, we love you, you're doing this out of love and all, that helps kind of getting it all together. Awareness about non-smoking, it it should work. In technically speaking, it should work. I mean, there are horrible pictures on the cigarette packets as well, but that has not stopped people from smoking. So I'm not sure what more can be done about non-smoking, but I think it's decreasing over the period now. Like, it has come down quite a lot. I'm not sure about the numbers, but I think it is coming down slowly. But yes, I agree with you. Creating awareness about the hazards of smoking is an important point. In corporate hospitals, even such patients are put on ventilator where it has been difficult to wean patients off, and eventually patient dies of. Yes, I agree with you. So as I said before, they are more afraid of taking the patients off the ventilator because of the medical legal aspect of it. But thankfully now the the Supreme Court judgment said that if the doctors feel that it is futile to continue the ventilator, they said that to form a board of doctors who will say that it is futile and you can wean the patient off before. Wean the patient off, like you can stop the ventilator and withdraw the treatment as well. It's just a lot of technicalities. You need to have two board of doctors, first level and second level, and if they both agree with it, then you can withdraw the treatment as well. But yes, I agree with you. Patients usually die on ventilator, and that's why our country is amongst the last in quality of death rating. So yeah, I agree with you. So not only in India but across the globe. So basically, the maximum amount of financial crisis that they have for medical treatment is during their end of life, because they are in the ICUs and getting all the invasive procedures done. So that is the trend, anyways, which shouldn't be happening. So yeah. Anything else? Any other question?
I believe everyone has exhausted with their comments and questions. So thank you, Dr. Rutula, for enlightening us on the palliative care involved in non-cancer illness so much. I believe everyone here would have got a more clearer picture on things. Thank you so much. Of course, as doctor said, it is a very vast topic which cannot be covered in a 40-minute span. We also do know that. So please do feel free to connect with us in case you have any other queries related to the topic. And thank you, Dr. Anjali, for bringing in such a wonderful case presentation as well. I believe that also added value to today's discussion. So thank you everyone for joining in, and Dr. Rutula, we do look forward for such more wonderful sessions with you in future as well. And with a promise that we will be again meeting in the next session with another important topic and eternal eminent faculty. This is Sripriya along with Dr. Rutula and Mr. Anoop signing off from the KIPSECO Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you. Bye-bye.